But let's have a debate with Dr. Murphy and Dr. Spencer about
Which I don't really
ideal
like at
stents.
all.
You don't either?
Well, we're usually on the same side making fun of Meisner. So being on opposite sides is not really comfortable for us. So I did not roast Erin. So if she roasts me in her slides, then we know which one of us is more evil.
Oh,
I didn't.
Of course, if we're together, Meisner gets roasted. Yeah, okay, good. It looks like we stuck to the same thing. All right, I got given, we still don't have the ideal venous stent. These are my disclosures. All right, so if I'm on this side of the argument, then a couple of the issues that I see with our current stents is that sizing considerations can be really tricky. When the common iliac vein demonstrates a pre-stenotic dilation and the external is relatively small, it's really tricky to figure out how to size those stents or place them without migration or disrupting flow dynamics. Reconstruction of the bifurcation is still a thing that we don't have the right stent combination for. And understanding Murray's law is really important in that. We'll talk about that. And then finally, metal allergic patients are actually more common than one would think, 17% of women and 3% of men. The existing data is very confusing about whether or not we can safely place stents or not, and we'll look at that briefly. I know Patty showed you one method of how she does non-thrombotic stents, and this is how I do it. I literally mark the screen if I can see the crossing vessel, because as the stents start to deploy, the artery can push on them, they move, they twist, and it's really good to have a fixed thing on the screen that your eye can focus on. Then I perform the intravascular ultrasound to measure the size of the inferior vena cava. As the artery crosses, then I measure the stenosis. You can do it by cross-sectional area or diameter. In the video trial, 61% by diameter was what was used to be most accurate with symptomatic improvement, but that was for lower extremity stuff and not for pelvic pain. Then we can come down, measure the normal size of the common iliac vein. You can see that the curve in the pelvis always gets a little bit more narrow and can serve as an anchor point. And then you can measure the external iliac vein. So in the perfect world, where the patient's common iliac vein is only 2 millimeters greater than the external, you don't have to worry about calculations and things. You can place a stent that matches the size at the top as long as it's 120 or 150 centimeters long, comes around the curve and is anchored over a long segment in the external iliac vein, and you get great flow dynamics. But what happens when someone has a very similar size of their common iliac vein to their external iliac vein without a great anchor point in the middle? Then you have to decide whether you want to oversize this stent by only 1 millimeter in the lower portion, or whether you want to go up to 4 millimeters, which can sometimes cause a disruption in flow dynamics. And early on in my experience in this patient that measured at least 16 millimeters, if not a bit bigger in the common iliac vein, but then measured about 15 in the external and had a significant obstruction, we put a 16 millimeter stent. But it turned out this patient had very small inflow vessels, and her IVC wasn't very big, and she had multiple recurrent thrombotic episodes, even though the stents look like they're good. So over time, I've learned it's actually better to undersize the pre-stenotic dilation as long as you have at least 6 centimeters of length of the stent that is significantly oversized to anchor it. And here's another difficult sizing situation when there's a massive dilation of the common iliac vein, yet the external iliac vein is really small. And this is a man who had gonadal vein embolization for persistent pelvic floor and scrotal pain. He has a pretty significant iliac vein compression, we'll see here in a second, but the pre-stenotic dilation of his common iliac is huge by comparison to how small his external iliac vein is, and this can be a really challenging situation. Now, sometimes when the vessel's really large like this, you may be measuring obliquely and you might overestimate the vein size a little bit at the top, but certainly in this patient, the external iliac vein is significantly smaller than the common iliac vein. So in that scenario, I've kind of developed this trick where if I think I know what size stent I want to put in, you can blow the balloon up and then do a venogram and see how much space you have adjacent to the stent. Is it going to be floating? And if you undersize at the top a little bit, like on the right-hand side, you're okay as long as you have a long segment of anchoring stent below that. So in this patient, the mismatch was so huge, I chose to put in a short 18 millimeter stent at the top and then overlap a 18 millimeter wall stent down into the external iliac where I got some spasm. But a year later, he came back for some persistent pelvic things where we needed to fix varicose veins. And he has pretty good flow dynamics there. So that worked there, but it'd be really nice if we had some sort of tapering stent. It's really important, especially in non-thrombotic disease, but also in thrombotic disease, to pay attention to Murray's Law, which defines the size of vessels in a branching system to create the best flow dynamics. And it's the same in xylem in plants, in arteries, and bronchi, and it says that the cube root of the radius of the parent vessel equals the sum of the cube root of the radii of the daughter vessel. And when Raj used to show this, my head was spinning. I had no idea what it meant. So if you calculate it all out, it basically says if you have two 14 millimeter iliac veins, you should have a 17.6 millimeter IVC for the best flow dynamics. And if it's 16, it's 20, and if it's 18, it's 22. So obviously, you can't kiss two 14 millimeter stents into an 18 millimeter IVC and not run into problems with not only flow dynamics, but pain. So the technique that I use is that I usually stent the left iliac vein, and if the right needs to be stented, which it frequently does not after you've stented the left in non-thrombotic disease, you tuck the right-sided stent just up underneath it. But the problem is, if you stick that left stent out too far, you can still end up with altered flow dynamics there, and it's not perfect that way either. So I don't think we have the right stent for the bifurcation or a right system for the bifurcation in non-thrombotic patients yet. And then finally, we'll talk about allergies to stent components, right? So, wall stents are stainless steel made of chromium, cobalt, molybdenum, nickel, and manganese. And nitinol is 50-50 titanium and nickel, but every stent we have contains nickel. Every covered stent we have right now has exposed nickel components. The ViaFort is by Gore. It's under study right now, but my concern is that a completely covered stent, if it's shorter at the top, may be at a risk for migration, like the early short stents we put in were at risk for migration. And if it's longer, then you're going to jail the internal iliac, which you don't do with these open design stents when you bring them around the curve. So I don't know that that's going to be a perfect solution either. And then the question of nickel allergy, what do we do with them? Well, there's the suggestion that the processing of nickel with modern stent technology means we don't really have to worry about that. But the bench studies that we have are pretty limited, and most of the explanted stents that are in the literature were arterial stents, one in the right iliac and one in the left lower extremity, where they had true redness, swelling, rashes immediately afterwards. Nothing was helping. They got explanted, and it all reversed. There was recently a case study of 9 patients with nickel allergy. They were stented in the intracranial dural sinuses for intracranial hypertension symptoms. Follow-up was 2 weeks to 4 years, and these were all nickel allergic patients. They had no adverse events, and resolution of symptoms related to intracranial hypertension was achieved in all of these patients. If we look at this further, although nitinol is widely used in percutaneous cardiovascular interventions, a causal relationship between nickel released from the implanted device and adverse systemic or biologic responses hasn't been established yet. So patients will say, why would you put something in me I'm allergic to? But if you look at the implanted devices put in and then explanted in animals, the systemic nickel concentrations in the serum and urine were not significantly different with implantation or explantation. And the stents that didn't have the optimized surface finishing had significantly greater nickel levels in the surrounding artery, but this was all arterial again and not venous, and it showed some thickening and narrowing. So they feel that if proper polishing is performed, we may be able to place these stents in patients who are allergic. And we are currently doing a retrospective review where we were trying to get 30 nickel allergic and 30 non-nickel allergic patients to compare their outcomes. When we did it retrospectively, we had 24 nickel allergic patients we've implanted. And until I have one patient now with severe back pain that is prolonged for 9 months, we had no reactions either in nickel allergic patients. And so we're going to have to do a better study on those, because what do you do when you do get that one patient where you don't know if they're having an allergic reaction? There's a dermatologist, actually, Dathan Heyman here in Arizona, who's studying implant reactions and says if you do a high-dose steroid pulse for a few weeks and they don't respond, it shouldn't be an allergic reaction. My one patient with pain did not respond. She wants her stent explanted, so I think it's a really tricky situation for us to try to understand. A lot of these patients have mast cell activation and other immune issues. And if you stabilize those, you can get the stent reaction to resolve in some of them, but if they don't, as you know, removing iliac vein stents is really dangerous and difficult. So stents in a perfect world, I think, would be stents that have, a small anchor to prevent migration so we don't have to worry about oversizing. Tapered stents potentially to improve flow dynamics in the iliac system, some type of bifurcated stent system at the confluence, and then if ever possible, some nickel-free self-expanding stents or a coating that keeps the nickel or the metal from being exposed in the patients.
Well, that's provocative.